Hi, my name is Anna Lagdal. I'm a consultant clinical psychologist at Great Western, and I'm also the lead for the cancer psychology team. So some of you will have met me already, but for those of you who haven't met me, if you spot me around on the board, please come and say hello. In today's session, I'm going to be talking about supporting patients through feelings of loneliness and isolation, which is part of the JACIE teaching sessions that you will have been doing this year. So as part of the session, I'm going to cover introductions, which I've just done, and then I'm going to talk a little bit about loneliness and isolation, about what it is, and then I'm going to move on to talking quite a lot about how to support patients emotionally if they're struggling. So loneliness and isolation, what do we mean by this? Well, loneliness is the distressing experience that occurs when a person's social interactions are, or are perceived to be, less in both quality and quantity than what the person desires. And it's important to consider here that people can feel lonely even when they're in a room full of people. So when they're objectively not alone, but they might themselves perceive their relationships to be insufficient. And feelings of isolation and loneliness are particularly common for people who have had a physical illness, so like cancer, and that can be for a whole range of reasons, some of which I'm going to talk a bit more about later. It's well established that feelings of loneliness can worsen both physical and mental health outcomes. So, for example, how somebody's illness progresses or not, but also loneliness has been found to be a reliable predictor for the development and prognosis of depression, as well as other things. So if we think about the wider context here, what are people being admitted for their transplant gone through already? So we can think about this both in terms of their diagnosis and their treatment. So how might they have reacted to their diagnosis? Did that come as a complete shock? Was it something that they might have expected? Was there a long lead up to it? Was it complicated? Did that feel very difficult? Did that perhaps result in a mistrust of healthcare professionals? Also, how did they find their treatment? Did they have to be admitted several times during the course of their treatment so far? So typically people will have gone through chemotherapy. So might you know them already? Is it the case that they've never been admitted to hospital before and this is their first time? So these are all important factors to consider. And then if we think wider than that even, what has the person been through in their life already? So might it be that they have experienced particularly difficult circumstances? They might have been through traumas in their past. So it's important to know all of these things because all of those things will then impact how the person responds to treatment and how they find the admission in itself. And if we think about the types of emotional distress that are commonly experienced by patients with cancer, the first one is worry. So stress, fear, panic. That might be about their future. It might be about the here and now in terms of how it's impacting their life. This can be linked to family relationships. It can also be linked to financial worries, but more typically it tends to be linked to the illness itself, the disease, and how this is going to affect their life, the length of their life perhaps, and the people that they love. Low mood or sadness, despair are also very common feelings that people experience. So that can be linked to feeling very unwell physically, for example, and feeling very low as a result. It can be linked to a loss of identity and ability to do the things that are important to them. Feelings of isolation, which is obviously today's topic, but here I'm thinking about this in a more existential way. So people talk about feeling alone in a world of their own where nobody can quite understand what their experience is like, and as much as people try, there's a sense of disconnect with other people. There can be confusion or struggles with uncertainty, and that can be the uncertainty that generally exists, or it can be general feelings of being unsure about decisions that they might need to make, for example. vulnerability is another really common experience, and I think that's particularly relevant when somebody is admitted as an outpatient, as an inpatient. They might be feeling very vulnerable. They're in a position that usually only very few people would see them, sort of lying in a bed. But now suddenly they're being exposed to being seen by a lot of different people, having to interact from a place of physical vulnerability as well as emotional vulnerability. There can be feelings of hopelessness in terms of perhaps treatment not working as planned, or feeling like it's not going to work, worrying that it's not going to work. There can be anger, where people can feel threatened, but they can also come across as threatening. And more generally, things like existential and spiritual concerns. So I'm thinking here about awareness of mortality and perhaps loss of meaning and purpose in life, as well as a deeper sense of disconnect that we talked about earlier. So as somebody is admitted, how might these feelings that I've just talked about impact their inpatient admission? So the obvious first point is the exacerbation or continuation of pre-existing feelings. Their emotional resilience may already have been quite stretched, so they've had to reach deep inside to get through particularly difficult circumstances, and then they're having to get through another hoop now in order to hopefully get better. For some people, it will be about prolonging their life. Relationships may already be strained. It might be the case that they're worried about people that they care for or who are dependent on them. And as I was saying earlier, undergoing stem cell transplant will likely increase patients' awareness and thoughts about their mortality. And as they're in hospital, they might have more time to think about that. As they feel very, very unwell physically, that might result in those thoughts becoming a lot more apparent and perhaps more frightening as well. And on the whole, people talk about reflecting on their life and the possibility of their life ending sooner than anticipated, which can be a very lonely experience. And what's helpful perhaps to know here is that before somebody has their inpatient admission for their stem cell transplant, they will have had a psychological pre-transplant assessment or a consultation with me, typically. And this consultation covers a range of different things that include things like the patient's feelings about the transplant, any potential previous history of psychological or mental health difficulties, any traumas that they might have been through and how these were reflected in their life at the time, but also how those difficulties could potentially be linked to how they cope with the transplant. And I also cover helpful coping strategies as part of that. So I try to draw a lot on people's existing coping strategies and help them think about if they were to struggle during the transplant, how might they draw on those coping strategies. But sometimes it might be that I introduce new coping strategies for them to think about as well. And I write up a report from that psychological assessment or consultation, which will be available on Careflow if anybody ever wants to look at that report. And then once discharged from hospital, all patients will have a post-transplant consultation with me as well. And that tends to be about 4 weeks after discharge. And again, that's to check in with people, see how their return back home has gone, how their recovery is going, but also how they're coping psychologically with all of this. So if we think now about responding to emotional distress, we're going to talk about a range of different things. So the first one is about connections. The second is about listening and exploration skills. The third one is the listening environment. And then finally, I'm going to just talk very briefly about when somebody might need referral or reconnecting back for specialist psychological support. So starting with making connections, why is this important? Well, making connections is important whether a person is struggling emotionally or not. It is the basis for all communication work, And it's helpful to know that people are much more likely to open up to you if you have formed a connection, which makes sense. That's how we work as human beings, isn't it? That if we feel connected to somebody, then if we're struggling, we might feel more likely to then want to talk to them about something that feels difficult. And as part of this, it's helpful to acknowledge your impact here, because as a healthcare provider involved in your patient's daily care, you are uniquely positioned to be a meaningful source of social health for them. So through your interactions, you can help them feel supported and cared for. You can listen empathically, you can show them kindness, you can earn their trust and be there for them in ways that others cannot. The ongoing relationship that you build with each patient contributes to whether they feel alone or connected during their inpatient admission, and in turn, how their health, so both physical and mental health, also progresses. And that can feel like a big responsibility, and it is a big responsibility. You're not alone in holding that responsibility. There's a range of different people who also carry that responsibility with you, but it's helpful for all of us to think about our role in that, because if we can all think about the part that we play, it's the sum of all of those parts that enables the patient to feel supported and connected, and which will make it much more likely that they will open up if they're struggling. So if we think about the listening environment can be really tricky on a ward sometimes because there's lots happening. So when I have my psychology sessions with people, it's often the case that some machine will start beeping, or somebody needs to come in to give medication or check if what somebody wants to eat, so their menu choices. So it's important to first of all think, well, what is the environment likely to be like? Do I know that actually I'm going to be called away? So if I know that somebody's been struggling, if I go in right now and start a conversation with them, I will probably need to leave fairly swiftly, which might feel quite invalidating for the person potentially. So I'll just make sure that I've got at least 10 minutes to chat to the person properly, and that I know that I'm not likely to be called away, or I know that I'm definitely not going to be called away at least. So having the time to listen. And the second thing is who can hear you. So privacy can be a funny thing on a ward, and obviously our patients will have their own side room, which is really positive, but things like, is the door open or is the door closed, for example, and are there other people around doing other things? Are the family members there? Sometimes the person might not be bothered about saying things in front of family members. That might be fine, but other times that might play a big role in how much they open up or not. Things like how quiet it is around. So I tend to suggest to people that, if I'm going in to have a chat with them, if we can turn off the TV at that point, if they've got the TV on. I try and make sure that they're comfortable. So if I can see that they're visibly not comfortable, thinking about doing something about that before we start the conversation. And all of these things aren't always possible. Sometimes there'll be an interruption because a machine starts going off, for example, but these little things can make a really big difference if somebody is starting to open up and talk about things. And then if we think about the non-verbal elements, so how far we are from the individual, we all know that if somebody stands too close to us, for example, that it can feel a bit intimidating or a bit difficult to open up because we're too close. But also if somebody's really far away, then you need to speak really loud, and that might feel a bit strange as well. So just considering the distance that we have to somebody, if we're moving around or if we're standing still. Being at the same eye level is really helpful if possible. So trying to sit down, if we're going to have a conversation with somebody, trying to be on the same eye level as them, given that they will often be in a hospital bed, for example. Thinking about things like eye contact, and again, that is something that people will be more or less comfortable with, but trying to maintain eye contact and not looking down at notes or looking at other things, but staying connected in that moment and, listening and watching. And sometimes people might look away if they're talking to us because they find that it's difficult for them to open up completely if they're looking at us, for example, or sometimes they might be thinking about something, so they might look up to the side. But for us as the listeners to be there as a steady source of eye contact in ways that feel appropriate. So posture again, how we're sitting. Typically, people can sometimes lean forward when they're listening, and that can be fine in the moment, but on the whole, try and sort of sit back in the chair so that we're not too close again, and just providing a sense of relaxed sort of posture where somebody feels comfortable talking to us, like we're not uncomfortable, we don't look uncomfortable ourselves, for example. Touch is something that can feel difficult sometimes, because naturally we have to touch patients as part of their treatment often, or you have to touch patients as part of their treatment. But it's about so where I put touch here, it's more in relation to emotional distress. So if somebody is distressed, do they want to be touched, or don't they want to be touched? And because we're so used to physical contact while on the ward, it can feel very natural to touch somebody if they're feeling upset as well, but that might not be something that they want. Other people really like to be touched. I would say if in doubt, it's better not to touch somebody. And if we do feel that it's appropriate to touch somebody, if they're feeling upset, it's just about thinking which part of their body. So perhaps holding somebody's hand, or just putting your hand on their arm, for example, or their shoulder, and watching their reaction to that. And we can usually see if that's something that's welcome, or if somebody looks uncomfortable with physical touch in relation to distress. And the other thing is attention, so thinking about how we respond when somebody is talking to us, if we're, again, looking through the notes, or if we're looking at other things in the room, if we seem like we're being attentive. And using things like encouragers, so nodding, facial expressions. And just, we don't sometimes need to say anything. Sometimes saying something might be disruptive, but if somebody has a lot to say, we might just sit there and nod, or we might smile, or we might make an empathic facial expression. It's about showing that we're listening and that we're fully there in the moment with them. And then the verbal elements, so tone of voice. So tone of voice is really important when we're talking. Typically, it tends to be the suggestion that we use a tone of voice that's calm, that's quite low, but not a whisper so that somebody can't hear us, but a sort of a comfortable and caring tone of voice, but one that conveys empathy and understanding. In terms of the volume, again, like I was saying earlier, not speaking too quietly, but definitely also not too loudly. Some people have a louder voice than others. Others have a quieter voice. And I guess it's about knowing that and knowing how to adjust that. Some people speak very, very quickly. And again, that's something to consider, that when somebody's emotionally distressed, it's quite hard to take in very fast speech. Equally, it can feel very frustrating listening to somebody who's talking very slowly. So again, it's about adjusting the speed of speech and making sure that it's appropriate for the moment. Jargon, so things like avoiding too many big medical or psychological words, and using somebody's name rather than, for example, sweetheart or honey or lovely, for example. That typically people tend to prefer that we use their actual name and that we check with them what they would like to be called. And again, those other verbal encouragers. So rather than saying a lot, we might say, yes, yeah, tell me a bit more. So not too many words, but just something about using those verbal encouragements to show that we're there, but without really reflecting too much on what somebody said. And then it's use of language more generally, so things to consider and or avoid. And these will typically be things that people will be aware of, but things like I said earlier about checking what somebody wants to be called. So again, people have nicknames. They might like for certain people to use those nicknames, but not others, for example. And then also thinking about use of language such as these expressions like "you're a star" or "bless you" or "poor you" or "you're so cute" even. I've heard people tell me that they've been told. And I guess there's just something there about the power difference that exists already when somebody's vulnerable in a hospital bed, and thinking about the way that we convey our position as not being somebody who can talk down to the other person. And that might not be done intentionally at all. Usually it's not done intentionally, but it's about just considering when we use a certain type of language, how might somebody then feel, especially if they're in that vulnerable position. And if we're thinking more specifically about eliciting or encouraging talk about distress, sometimes again it's about not saying too much, but using expressions such as "it sounds like this is really hard for you," or "gosh, it sounds like you have really strong feelings about that," if we're not quite sure what somebody's feeling, but we can tell that they're quite distressed about it. Or we might simply say, "could you say a little bit more about that?" if we just want them to explain something. Typically, we might have a sense of what somebody means when they say something, but asking them to say more ensures that we have a good understanding of what they actually mean. And then thinking about barriers to exploration. So these are all things that are often well intended, but they can stop somebody from fully expressing how they feel. And the first one of those is offering advice or reassurance before the issue is explored. So if we see that somebody's distressed and we maybe have limited time, it's easy to want to jump to a position where we offer advice or come up with suggestions about what somebody should do, or we say, "don't worry about that," for example. But giving somebody the space to really talk through how they're feeling and asking them more questions about it before considering what needs to be done typically tends to result in somebody feeling heard and validated. And often that might be all that's needed. And sometimes we can even ask them that question. We can say, "would you like me to offer you some sort of suggestions of what might be helpful, or do you just find it helpful to talk about how you're feeling?" And that tends to sort of give us the answer of what's needed quite quickly. The second one is explaining away distress as normal. So say, "yeah, don't worry about that, that's completely normal." And there's a fine line between that reassurance of normalizing something and about explaining it away. And what I mean by that is that it can be helpful for people to know that, yes, others experience this too, but that doesn't mean that it isn't distressing in its own right. So a little bit like somebody might feel very nauseous, or they might experience sickness as part of their treatment. Now, while that's completely normal, that doesn't mean that we say, "yes, that's just normal," and we leave it there. But instead, it's about thinking, well, what can we do in support? Because that will still be really, really distressing. The third point is about tending only to the physical aspects. And that can sometimes feel safe because the physical aspects might be the bits that we have solutions to or answers to. But just making sure that we're providing space and time for the psychological or the emotional aspects as well. The third one is about changing the subjects, and sometimes we might do that without meaning to, because we had something in mind that we wanted to talk to the person about, or something that was important that we've been told to check with them, for example. But just making sure that we allow them the space to talk about the thing that they need to talk about before moving on to anything else that might also need discussing. The other one is jolling people alone, so trying to be jokey can feel incredibly validating if somebody's struggling. And again, it might be very well intended, but it's generally something that we should avoid. And finally, encouraging patients to be positive. There are a lot of misconceptions about positivity, that people think that there's a link between things like survival and positivity, for example, which definitely isn't the case. There's been quite a lot of research on this, and positivity doesn't increase survival at all. And psychologically, what we tend to find is that people who try to be positive when they're not feeling positive generally tend to end up feeling worse, because they're pushing all of those feelings down instead of dealing with them and having the opportunity to express them. So the last point I'm going to cover here is just about discussions about difficult conversations from your point of view, because we all have our own life experiences that we come with, and there's something there about knowing what kind of situations you might find difficult to talk to people about. So that might be because you feel like you might need more training, or you don't feel confident in covering particular topics, or it might be that it brings up difficult memories of something that you've been through, for example. So it's just about being prepared and knowing within yourself what kind of situations, what kind of topics, what kind of distress might be difficult for you to support somebody with, and making plans around that. So that can be to request more training if that's what you need. It might be that a particular person is very difficult for you to care for, and then you might talk to your colleagues about that, because it might not be there that it's appropriate for you to do the majority of the caring for that person because of their circumstances. But it's just about being aware and knowing what triggers us in particular. So just to summarize the points that I've talked about. So firstly, when you're responding to distress, just remember to stop and be fully present. Appreciate the environment, so think about what's happening around, whether it's a safe environment for somebody to talk within, and just remember to bring your empathy. So empathy doesn't mean that you feel the same as the person, or that you necessarily agree with what they're feeling or what they're thinking about something. It's about providing that space where you have a complete understanding that that is how they're feeling, and you don't make any judgments on that. It's about being aware of the non-verbals, both theirs and yours, so also what messages they might send through their non-verbal channels. And finally, where appropriate, and only after you've discussed this with a patient, it's also about considering whether putting the patient back in touch with psychology might be helpful. And generally speaking, because somebody's had the pre-transplant assessment, they will know who I am. They might associate psychology, for example, with an indication that they're really struggling, and they might not feel like they're really struggling. And it's important to listen to that and hold that in mind, but also maybe put the thought out there. If you think that somebody seems to be really going downhill and they're really struggling, and you think, you know, they might need a bit of extra support here, maybe putting the idea to them, and then it's something that you can come back to a couple of days later, perhaps once they've had a chance to digest that. Now we've reached the end of my talk. Thank you for listening to this, and good luck with the quiz, which will come up on the next page. If anybody's got any questions, or they would like me to talk them through anything else, I can always be contacted, or if I'm around on the ward, feel free to come and talk to me. But otherwise, good luck.